Stephen Melek has been a principal and consulting actuary with the Milliman since 1990. He has worked extensively in the behavioral healthcare field and specializes in healthcare product development, management, and financial analyses. He has chaired and served on various societies of actuaries and the American Academy of Actuaries task forces and working groups, most of which have been focused on behavioral healthcare issues. He has a BA in mathematics from the Illinois Institute of Technology. Welcome, Mr. Melek.
Good afternoon, Chairman Andrews and members of the Subcommittee on Health, Employment, Labor, and Pensions. It is my pleasure and honor to testify before you on the Paul Wellstone Mental Health and Addiction Equity Act of 2007. My name is Steve Melek, and I am a fellow of the Society of Actuaries and member of the American Academy of Actuaries. I'm a healthcare actuary with Milliman, which is a leading actuarial consulting firm that consults to virtually all health insurers and managed care plans in the U.S. and many employers. I've been with Milliman for 17 years and have specialized in actuarial work related to behavioral health care. Our report contains the findings of the Milliman authors. Please note that Milliman does not endorse legislation. My work with Parity dates back to the analysis of the Health Insurance Reform Act of 1995. I've personally helped health insurers, providers, employers, managed behavioral health care organizations, and state governments price behavioral health benefits, including legislation in Nebraska and Washington state within the last year. Milliman was commissioned by Capital Decisions, Inc. on behalf of several behavioral provider organizations. Our full report contains important details about our findings, sources, and methodology. From an actuarial standpoint, Parity will bring the benefit limits and cost sharing for behavioral health care in line with medical benefits. For example, a benefit plan might have a $10 copay for an office visit for a medical condition, but a $25 copay for a therapy visit to a psychologist. In addition, a benefit plan might limit behavioral therapy to 20 visits per year, but have no physician visit limits for medical conditions. Obviously, that can increase costs for the insurer or employer, and it will decrease the amount the patient pays out of pocket. Our estimates show that the cost increase is modest relative to total health care costs and to the ongoing annual cost increases of health benefits. We estimate this legislation would increase per capita health insurance premiums of typical health plans in 2008 by an average of 0.6%, or $2.40 per member per month in our baseline scenario. In that scenario, we assume that employers and health plans will take no steps to compensate for the added cost, such as increasing cost sharing or increasing utilization management. Thus, our estimate is conservative, meaning it's on the high side. Employers and insurers commonly try to compensate for increased costs by reducing benefits or increasing employee premium contributions. The CBO, in its cost analysis of Senate Bill 558, considered that employer responses will remove about 60% of the cost increase. Applying this CBO figure to our baseline scenario increase of 0.6% reduces the net cost increase to about 0.2%. Another response of employers and insurers to increase costs is to increase the intensity of utilization management. The legislation does not appear to prevent the use of utilization management, or UM. We developed another scenario, our increased UM scenario, where payers would tighten their behavioral health care utilization management. In this scenario, our cost estimates result in an aggregate premium increase of less than 0.1%, or 3 cents per member per month. As members of the subcommittee are well aware, there is enormous variation in the health system, and the increase for any specific insurance plan will vary with many factors. While we can construct a set of circumstances where the cost increase for a specific plan could be 1 to 2% or more, we believe such plans cover a small portion of the people with group health coverage, probably less than 5%. Increasing benefits for behavioral health care services may result in reductions in other health care and employer costs. This is because better behavioral health care can improve a person's medical conditions. It may also lead to an increase in the use of psychotropic drugs. We did not consider these effects in our report. We assume coverage consistent with DSM-4, but we did not include treatment for tobacco use, obesity, or the side effects of medication. We provide some information and references regarding the well-established evidence base for diagnosis and treatment of mental and substance-related disorders, which is on par with that for diagnosis and treatment of medical and surgical conditions. We also summarize how this evidence should be used for medical necessity determinations by payers in the utilization management process. We also present summary information from Thompson Healthcare's work for SAMHSA. It shows that spending trend increase for mental health and substance abuse-related services was less than that for total healthcare spending between 1993 and 2003. Future growth in behavioral spending is also projected to lag other healthcare spending, partly because there is less new technology expected for behavioral than for medical care. Another trend we report is that the private insurance portion of national mental health spending increased from 21% in 1986 to 24% in 2006, while substance abuse disorder spending decreased from 30% to 9%. Thank you again for the opportunity to present our report today.